I would like to welcome all of you to this RDLS session on DTG transition. So today to facilitate this session, we have Dr. Ramesh with us. He's a public health specialist with the Centers for Disease Control based in Delhi. So he will be taking us through this session today. I welcome him on behalf of ITEC and also Manipur State AIDS Control Society. And I would like to thank all of you for taking out time and joining for this important session. So yeah, over to you, Dr. Ramesh.
Yeah, so good morning all. Good morning, Vipin, for the introduction, and thank Manipur SACS and ITEC for giving me this opportunity to deliver this session on transition of TLD. This is an important session, so some will be very practical now, some will take time to implement. So you need to understand what you have to do immediately. For what you have time, that is yet the guidance has to come from NACO. So don't think that everything after this session needs to be implemented. This is a stepwise process. So you have to understand what you have to do first. And then at the level of SACS, what are the interventions we need to see at site level what. So this presentation I will try to cover. And before every important concept, I have introduced certain questions. So you have to use your chat box to respond to some of these questions so that we know where to stress, where not to stress. I'll just share my presentation. Yeah, all are able to see it?
Yes, sir.
Yeah, good. So first slide, we will look on the mechanism of action of dolutegravir, okay, DTG. So before that, I want you to use your chat boxes, everybody. So the first question is, DTG refers to darunavir or dolutegravir. So you have to put like A1 or A2 as your response in the chat box. 30 seconds. Use the chat box, please. There's nobody typing, please. You have to use your chat boxes, not just attending this session. Attending this session in a participation will be very helpful for both of us. Yes, very good. Purnima has started it. I don't see this anybody from REMS, GenMs. No, it's only the ITEC staff who had responded. I want you to open your chat boxes. I will take time. I will wait until I get the responses. I'm not going to move forward. Use the chat box and put your answer. Okay, now the second question. Dolutegravir is a protease inhibitor. What's your answer? Is it true or false? Question C. Raltegravir and dolutegravir belong to the same class of drugs. Dolutegravir and raltegravir belongs to the same class of drugs. Good. It is worth for all of us to listen to this because of the limited responses I've got for these questions. Half of you did not respond. I take it that you do not know. And half of you responded with 50% correct answers. So everybody be very attentive to what I'm saying in the next few slides. Yeah, here you see the classes of drugs. We all are aware of NRTIs, NNRTIs, NTRTI, fusion inhibitors, protease inhibitors. So some of you have answered that dolutegravir is a protease inhibitor. So don't get confused with the darunavir. Darunavir and dolutegravir are different. Dolutegravir is a integrase inhibitor. What you see in the center of your slide, the integrase inhibitor. So dolutegravir is an integrase inhibitor. And you can see just about dolutegravir, there is raltegravir. So raltegravir and dolutegravir belong to the same group of drugs, that is integrase inhibitors. Some of you have put this also wrong. So just correct yourself that raltegravir and dolutegravir belongs to the same group of drugs, that is integrase inhibitors. And dolutegravir is not a protease inhibitor. Don't get confused with darunavir. Darunavir is DRV. Dolutegravir is DTG. So these are the basics before I proceed to the presentation. Yes, here you see this life cycle of HIV virus. Most of you know it. And where is this step going to take place is, it prevents the integration of the human cell genome with the viral genome that is going to take place in the nucleus of the human cell. So this is the step where integrase inhibitors act. Now, why do we need dolutegravir based regimens? We have many regimes with us. We have NRTIs, we have NNRTIs. Okay, we also have other groups of drugs such as fusion inhibitors. But why are we more worried about introducing dolutegravir into our national program? So there are a couple of studies that have been done, but one important study is a single study. That is, it was done on all patients who did not receive any antiretroviral therapy before. So they have compared with dolutegravir, abacavir, and 3-TC is lamivudine. So this study had shown that when patients are giving dolutegravir, abacavir, and lamivudine, vis-a-vis TDF is nothing but tenofovir, TLE. So they have compared TLE versus abacavir, lamivudine, and dolutegravir. You can see that in 88% of the patients who are on dolutegravir based regime compared to TLE based regimen, within 48 weeks, 88% of the patients have undetectable viral load. That means rapidly patients have developed undetectable viral load or viral suppression. And you can also see that most of the patients, even at 96 weeks, they remained virally suppressed compared to patients who are on TLE based regimen. So two important things that you need to remember about dolutegravir is, it rapidly suppresses the viral load, number one. Number two is, it not only suppresses rapidly, but there is a sustained viral suppression that you see whenever a patient is put on dolutegravir based regimen. So two important points from this is rapid viral suppression. Next, this rapid viral suppression, whatever you get, is sustained for a longer period of time compared to the current first line drugs that we use, that is TLE. This slide shows the same thing. You see an yellow color and a gray colored line diagram. So a trend line, what it shows is within 8 weeks, see the circled one, within 8 weeks, more number of patients had a viral load suppression compared to the yellow color, which is of TLE. So the same thing that we are seeing here. And what about side effects? So in your practice, while you are using TLE or any other NRT and NRTI PI based regimens currently that we use, if you ask patients, why are you discontinuing treatment? One common thing they will tell you is about, so the side effects of that are too harsh that I had to discontinue the drug. So the third most important point about dolutegravir is it has fewer side effects compared to the current regimes that we are using. Now, the other very important point is it has higher barrier to resistance. Now, when we say higher barrier to resistance, what does that mean? This slide will explain what it is. You can see on this slide, you have almost all the drugs that we are using in our national program. You can see zidovudine, you can see D40 that we used earlier, abacavir, nevirapine, 3TC, efavirenz, raltegravir, dolutegravir, and all other drugs you are able to see here. On your y-axis, you are able to see the barrier to resistance. When I say barrier to resistance, that means it is the ability of the drug to not to have this resistance early. And potency means to act on the patient. So if you see dolutegravir, which is in the right side upper quadrant, that means this drug has a higher potency and it has a higher resistance barrier. But if you see raltegravir, which again belongs to the same group of drugs, it has higher potency but a relatively lower barrier to resistance. That's why you have to remember in the national program, why are we switching from raltegravir to dolutegravir? You would have changed some of your patients, especially the COE and RIMS Imphal would have recommended most of the centers to switch patients who are on raltegravir to dolutegravir. Both belong to the same class, but why have we taken this decision is, you can see in the purple color to your right side of the graph, RAL, raltegravir is in the bottom, dolutegravir, which is encircled, is in the right upper quadrant. That means dolutegravir has higher potency and a higher viral resistance barrier compared to raltegravir, which is only potent drug but which has a relatively lower barrier to resistance. And there is one observation that is seen while this was given to pregnant women and newborn children is they have seen that in this particular study that children or the early analysis had showed that there were neural tube defects among women who were taking dolutegravir at the time of. So the similar thing, if you remember, most of the medical officers or counselors involved here, if you see that, we have seen this similar sort of evidence which was emerging from efavirenz initially. Initially, we were not giving efavirenz to pregnant women. We were just continuing on nevirapine. Later, the evidence has accumulated and shown that there is no much effect on, again, neural tube defects or on childbirth among patients on efavirenz. So similarly, we are at this stage of evidence where the evidence currently states that pregnant women after conception who are in this childbearing age group, we need to be careful about the neural tube defects. About this, I will talk to you in length in my coming slides. So we should not have in our mind that this is contraindicated in pregnancy. No. this drug is very to be looked into care in women of childbearing, okay, because the benefits of this are very high compared to this. Now, if you see what are the benefits of taking dolutegravir on pregnancy while pregnant is, number one, it will suppress the viral load very fast. So the child getting HIV status is very, very, very minimal. Number two, this will also help in discordant couples. This will also help in sexual prevention of sexual transmission of HIV. So these are all the benefits of using this drug. So my first bullet, if you see benefits of DTG in women of childbearing potential, include maternal viral suppression, maternal deaths, and fewer sexual transmission. These are the real benefits for prevention of HIV. Vis-a-vis compared to the risk, the only risk that we have is a minimal neural tube defects we see in women with childbearing potential at the time of conception. Yeah. Now, in summary, if I have to summarize all the slides now, dolutegravir should be used in the program because of its rapid viral suppression, fewer toxicities, a more potent regimen. It has a higher viral load barrier and a minimal drug interaction. This drug can also be used against HIV too and can be used with a single dose regimen. Now, again, I want you all to use your chat boxes. Question 4. Put 4.1 or 4.2 as your answers. Dolutegravir has high genetic barrier and high potency compared to raltegravir or efavirenz. True or false? Use your chat box. So there is something called as chat when you are doing it. So use the chat box. Of people who do not know to use that, I'm telling. Rest of the people are not in your seats or not attentive. Yes. Now question number 5. DTG is contraindicated in pregnancy. So I need you to your responses in the chat box. 5.1 or 5.2. Faster, please. There are only 2 or 3 active participants that I can see. PCOA, Jennings, James, Bueno. Just now we got from Chorochandpur. So who all have put true? Again, listen to me properly, because this is the accidental message that you will be giving to everybody, because now it is not even 2 minutes after this presentation. It is not contraindicated in pregnancy. Okay, it is not contraindicated. When I say contraindicated means if she is pregnant, I don't give it. It's not that situation here. Here we are saying, look at the merits and demerits of giving this drug. And if a mother who has in second trimester or third trimester, we are telling to give this drug. So more potently not in the first trimester. So the answer for that is it's not contraindicated. We need to weigh the risks and benefits, not a direct statement coming from you all that it is contraindicated. Okay, good. DTG is safe after first trimester. True or false? Waiting. Yes, it is safe after first trimester. Good to see your responses. Thank you. So now we just have seen how the Drugs Act. Second one, why dolutegravir is important. What are some of the risks of this? And then now we are going into adverse events or drug interactions. Please be attentive here too. Right. So the side effects of dolutegravir, if you see, insomnia, headache, dizziness, tiredness, allergic reactions. So can you name one drug which has the similar side effects that we are currently using in the national program? Anybody? One drug which has a sort of similar side effects that we are using in the national program. Very good. Peter, it's efavirenz. It's efavirenz. It's not TLE, it's not tenofovir, it's not lamivudine, it's only efavirenz. Good. So efavirenz is having similar. Now, in the presentation initially when I started, I told you that the side effects of dolutegravir are relatively less. So what you need to bear in mind is, though it has this insomnia, this is not so severe as that of efavirenz that you see. Okay, so this is very transient. It just takes few days, 10 to 15 days for the side effects to subside. So it is only reassurance that is required. But for efavirenz, it is very severe. Most of you who are practicing now knows that. Now there is another observation that they have seen for dolutegravir is dolutegravir associated weight gain. So it's only an observation where from the studies that have been conducted, it has shown that patients who are on dolutegravir based regimen have increased weight over time. So this is one thing what we will have to start doing. Counselors will have to counsel patients who will be transitioned to dolutegravir based regimen. Next slide is, there are some key drug interactions. I want most of you to concentrate on the last three, very importantly, which we use more common, which more HIV patients present with. For example, if there is a patient who is on anti-diabetic drugs and specifically metformin, the limit of this metformin dose should not be more than 1000 milligrams whenever we are using DTG. And glycemic control should be monitored. And most of our patients will be put on antacids or they'll be put on multivitamins and other supplements. It is recommended that these be used 2 hours prior or 6 hours after taking dolutegravir. And patients on rifampicin, whichever patient is on rifampicin, please listen carefully. Whichever patient is on rifampicin, they need to get an additional dose of dolutegravir 50 milligrams. Okay? Whoever is put on concomitant TB treatment having rifampicin based regime, they need to get an additional dose of 50 milligrams along with the DTG that they get. So now what you will see are the NACO guidelines that have been issued in the month of May. So in the month of May, the guideline says that all patients who are on raltegravir based regimen, listen carefully, all patients who were on raltegravir based regimen need to be switched to dolutegravir based regimen. So I think this has happened in Manipur I think it's mostly under the COE and PCOE where this has occurred. So has this started in Manipur? How many patients have been transitioned or are switched to dolutegravir? COE or PCOE can respond in the chat box. Yeah. So when they were switching these patients who are on raltegravir based regimen, so whoever had raltegravir and were on lopinavir and ritonavir based regimen, this particular slide, see very carefully, there is a dose change. So I have put red color. So patients who have unsuppressed viral load on raltegravir and lopinavir, but will need to be transitioned to dolutegravir, they will get an additional dose of 50 milligrams BD. That is, both in the morning and evening, they will be getting that additional dose. And also you see raltegravir and who are on darunavir based regimen, the same thing, an additional dose. So this particular slide is already we started to practice this. All patients on raltegravir are transitioned to dolutegravir, but it depends on viral suppression. For a patient who is not virally suppressed, they get a double dose. Either you are on raltegravir with darunavir or lopinavir. That is the difference that you need to catch here. Same thing, not much to emphasize. So question number 7. All patients on raltegravir with unsuppressed viral load should be prescribed BD dose of dolutegravir. True or false? Just one response. Four of you. Charu Chandpur and all who have earlier responded are not responding now. Yes. So you need to remember where you need to give a BD dose of dolutegravir. So one instance says all patients who are on dolutegravir with unsuppressed viral load need to get an additional dose of dolutegravir. Let us see what are the other instances where we have to give double dose. Now, this is the second guidance that we received in the month of July from NACO. Now, what this guidance says is, all patients who are on ZLN, the first step we need to do is to see their viral load. Their viral load is less than 1000 copies. Switch this patient to TLD. If a patient has viral load copies greater than 1000, we do a step-up counseling. Then we repeat a viral load. And if the repeat viral load is less than 1000, we switch that patient. Now, if the repeat viral load is greater than 1000, what we are doing is we are referring that case to SACS, either an e-SACS or a virtual SACS or a physical SACS. And then a decision of switching this patient is taken at the COE. But the drugs will be available at the ART centers. So a prescription or a recommendation will be made by the SACS, but the drugs can be continued at the ART center from where the patient is being referred to. This is the point to be noted. But all these will depend on SACS giving you that recommendation of go ahead with this. NACO has given a guideline now, but SACS and NACO will again tell you, okay, Manipur, ART centers, start practicing this. But before we start practicing, the first step what we need to have in place is the viral load test of all the patients who are on ZLN. So now I think the services for viral load has resumed in Manipur. So take advantage of this and start referring patients who are on ZLN, so that whenever the stocks of dolutegravir arrives to your state, you can start based on the drug stocks on ZLN and dolutegravir that you have in your state. So the first recommendation from my side will be to refer all patients who are on ZLN and who did not have the recent viral load for them to be pushed for viral load screening. Now see this very clearly. Can anybody tell me the difference between a patient who is on ZLN and who has more viral load copies, more than 1,000, and compared to a patient who is on raltegravir and who is not virally suppressed? Is there a difference in the dose? So on this slide, what you see is the only difference that you can make out for a patient who is on ZLN is there is no change in the dose irrespective of your virally suppressed or not. The only change is mechanism of referring the patient and a recommendation coming from SACS. But the dose is the same here, irrespective of failing ZLN or not failing ZLN. So you can ask me a question. Now, since we are giving the same regimen, why should this additional step of referring the patient, knowing his viral load count important? Can anybody answer this question? Why is it important for us to understand before we switch or substitute the patient to a dolutegravir based regimen? Why is it important for me to know whether the patient is failing ZLN or not failing ZLN? Anybody can respond? You can raise your hand, they will unmute, or you can also put it in the chat box. It's not a tough question at all. The answer is staring at you on this slide. Anybody responding to this? Why are we worried whether a patient is failing ZLN or not, even though we are giving the same drug, if he is suppressed or not suppressed? Why are we worried about his viral load? Both of them, you cannot put them as first line TLD or anything. When ZLN suppress, why do we need to change to TLD? Okay, your question is correct. Why are we doing it is, we want to give the best regimen to the patient. Okay, so a national program has taken a decision. Now we cannot debate on why, what, and all on that. But we need to debate on, even if there is a viral load count higher or lower, we are giving the same dose. So the answer for this is, suppose a patient who is failing ZLN, okay, suppose a patient who is failing ZLN and a patient who is not failing ZLN, you are putting them on TLD. And after some time, you see that a patient is failing on TLD also. Now, what is the next regimen for him when you are planning a next regimen? And if you find out that actually ZLN he was doing fine when ZLN was there, he had viral suppression, but because of program, we need to change into a better drug. So at that point of time, there is a chance that you can actually try the patient on ZLN. You're conserving certain other first line drugs that you're using now for his future therapies. You are preserving other options for him. So that's why now we are being safe in terms of, if these patients undergo resistance to TLD, which is not common, but what is the drug he has for his future options, these patients can be tested and tried on ZLN whenever there is a failure of TLD, if he is now suppressed to that therapy. Hope you have got the answer. If any doubts, you can again raise your hands later. Now, a revision question again. Patient on ZLN with unsuppressed viral load has the following prescription: TLD OD 50 milligrams DTG plus an additional dose of 50 milligrams DTG. Is this prescription correct? Fast. Just one response I've got. Faster. Good. So this is an incorrect prescription or a wrong prescription because he should just be getting TLDOD. That's all. Good. All are attentive. So now these are the operational guidelines that are going to come in the national program, which you should not worry at this point of what to do, how to do and all. So you need to remember that DTG will be the first line from whenever the OM or the national guidelines tell it. But DTG will be the regimen that will be used for all patients who are more than 20 kgs of age and more than 6 years. This will be the primary regimen for everybody. And it will be done in a phased manner, and operational guidelines or office memorandums will be released in a phase-wise manner. So what the upcoming guidelines tell is TLD will be the most common regimen which everybody will have, even if a patient has HIV-1 and 2 or only 2. And for patients who are on hepatitis B and C, who are on tuberculosis, who are with single dose nevirapine in the past, all these patients, whenever the guidelines release, all of them will be transitioned to TLD. Now, if you see, there are situations where a patient is weighing less than 30 kgs of weight. There we are giving apacavir lamivudine tablet and dolutegravir single dose. And all patients with high serum creatinine, this is one doubt which most of you are asking. In those patients, we are putting them on apacavir, lamivudine, and dolutegravir 50 milligrams once daily. So here we are not using tenofovir. All these guidelines are yet to come, so don't worry about that right now. And don't worry about the second line. Third line, what we are saying now is dolutegravir twice daily, darunavir and ritonavir. So twice daily, in which other circumstance you are using is for patients who are on third line, patients who have been transitioned from dolutegravir, patients who are put on TB treatment. All these patients will get an additional dose of dolutegravir. Now, what about in children? Just see this flowchart. It's going to be easy. So all children who are less than 6 years of age or less than 20 kgs will get abacavir, 3TC, lopinavir, ritonavir. They will not get dolutegravir at all. All patients less than 20 kgs or less than 6 years will continue to be on lopinavir, ritonavir, but they will not have dolutegravir in their regimen. Children between 6 to 10 years of age or weight between 20 to 30 kgs, they will definitely have dolutegravir. But their primary regimen will be anchored based on abacavir. And who are more than 10 kgs with more than 30 kg body weight or renal diseases will have, or sorry, without renal diseases will have tenofovir, that is TLD regime. So bottom line, what you need to remember is everybody less than 20 kgs will not have dolutegravir, more than 30 will have dolutegravir, even 6 years or more will have dolutegravir, but children will have abacavir as their primary regimen compared to tenofovir as their primary NRTI based regime. Same thing that I told. But for HIV TB co-infection, what you need to remember is, again, who are less than 20 kg, will be getting super boosted ritonavir, which we are currently giving. And for patients who are above 30 kgs, you see that there is an additional dose given to patients who are on dolutegravir. Either you are more than 20 kgs of. Now coming to PPE guidelines, PEP guidelines. Here what we are recommending is the better drug that we recommend for children again is ZLN based regimen. If it is between lopinavir or ritonavir, it is again dolutegravir. So this becomes an important piece. The only one adverse reaction or an adverse event that we can see is in the woman with childbearing potential. So at this point of time only the counselor should counsel the mothers who are going to be pregnant. If you're already pregnant, there is no problem. But who are going to be pregnant from conception, it's very important until first trimester. So this is one area where counselors have to look into. The broad principles we have seen. Key issues related to this are patient general concerns. I'm doing fine. Why my current drugs are changing? So this again question was asked by some of them. Here you have to tell the morely why dolutegravir is highly potent. Will I get all the side effects I had last time? Here you have to say now. You will not be getting. So this is the revised version of the MPR 14/2020, where dolutegravir is being reported separately and also with TLD. So very important operation steps that I want to discuss at this point of time is currently in Manipur, you have sufficient drugs of ZLN. So which you can easily have them up to 4 to 6 months. But very important point is now viral load has started. So within the next 1 month, please refer all patients with ZLN to viral load if they do not have, so that when our TLD comes in, you can transition. And who will be the first patients to be transitioned or who are all on raltegravir, or the patients who are waiting at the Center of Excellence or PCOE to get a SASAP referral. So all patients who are going to get a SASAP referral and recommendation, so there will be another first group of patients who will be transitioned to to TLD. So with this, if there are any doubts, I can take them. Either you can unmute yourself or you can have in the chat box if there are any questions. Any questions? Yeah, so there are no questions. Thank you all for your patient listening. And if there is any question, you can put them. Yeah.
Thank you so much for your detailed presentation. That was very helpful because this drug being a new drug, it is really confusing for all the centers.
Yes, ma'am. You muted yourself. Yeah.
Yes, I have unmuted. Okay.
Yes,
so I was saying, like Manipur at the moment we have not got our TLD because it was under quarantine at the warehouse earlier. But this time, our indent has been made, and they have arranged to give it supply it to us this time. But DTG plain DTG 50 milligram, we already got it. So we have already transitioned from Ralte to DTG at the moment. Now, in your presentation, you have already presentation you have already mentioned that DTG though not contraindicated, we have to take caution, especially in the first trimester and all the women bearing, childbearing women. So
Right.
like in this situation, because many of the people who have been initiated on ART are many are still in their young age, childbearing age group. So should we continue to make them use the drug uh, just in case they become pregnant? Of course, we do counseling all the time, but then how do we go about in this situation, in this scenario, especially? How do we
Yeah.
counsel, and what regimen should we make them to stick around? Because we know that they are in the childbearing age group, and we can't prevent everyone from not getting pregnant. So
Yes. Yes.
yes, please.
Yeah. Good question, ma'am. So uh, the first thing is we need to counsel in terms of why is TLD, that is the dolutegravir, what is its importance? Like I told you, it will reduce
Yes.
the maternal mortality, it will reduce the maternal transmission. It also has that sexual risk transmission also is reduced. So these are the benefits. If you are able to convince that, and the second important point is, even if you have convinced to your maximum and if there is a question of no, then these patients will be put on TLE, what we are continuing now on efavirenz based regimen. TLE will be given to them, not ZLN. TLE will be given to them.
Thank you for the answer, because I want all the centers to know this particularly.
Correct,
Thank you
correct.
so much. Yes.
There are other job aids also going to come to all the counselors and the ART staff and to the community. NACO is preparing those. So shortly you will get those job aids, which will be helpful for you to see those and explain patients. Yeah.
One question, sir, like uh, for those who are doing well in, supposing if they are not doing like with TLE 600 milligram,
Okay.
because of the efavirenz reaction, if they have been put on TLE 400 milligram and they are doing good, if they are doing good, will it be necessary for them to transition it to TLD? I mean, like if they are doing good in
Definitely
TLE
because
400.
yes, because there again now it is a subtherapeutic dose which is going now to this patient. So it will be beneficial for him if he is not facing any challenges with that efavirenz 400. Okay,
Yes.
many chances of he not getting any side effect with dolutegravir because he has already gone through that insomnia and all the other things. So
Right.
with introducing dolutegravir, there are no chances or very, very, very minimal chances of he getting. And the next advantage is this person will have, you can preserve this drug, TLE, for his future. Now, if you're putting on dolutegravir.
Okay.
Otherwise, tenofovir will also fail in him. If you just continue TLE, tenofovir will fail. That will again decrease the potency of TLD when you put him now at later stage. So
Okay.
recommendation will be better to put him on TLD now and use TLE for his later if he fails TLD.
Okay. Okay. Thank you.
Yeah.
Good afternoon, everyone. Dr. Ramesh, I actually joined late. I'm sorry, I was in another meeting. Wanted to just say thank you very much, sir, for doing this. And
No problem, ma'am.
yeah, thank you, sir.
Yeah. And last question to most of you, I thought of posing while in the session itself, but couldn't do that. So, for example, a TB patient has come and you have put him on double dose of dolutegravir. Now, should he continue that lifelong, or you're going to switch him back to single dose or substitute him back to single dose a TLD? What is your answer? Anybody? A patient has completed his TB treatment. After that, that additional dose of 50 milligrams of dolutegravir, are you going to stop or continue lifelong? Okay, I think there's nobody. Yes, we should stop. The answer is correct, Omkant. We need to stop that regimen. Okay. Thanks, everyone. Thank you.
Yeah. Thank you so much, Dr. Ramesh and Dr. Lucy also for taking this initiative. And thanks everyone for participation. I heard from Madan that all the centers are participating. So thank you,
Good,
everyone.
good. Yeah, thanks. Yeah.
Thank you, sir.
Thank you, everyone.
Today, nangi mutu off samane. Today, nangi video do off.